Go.
We're live.
We're live. Do you want me to start?
Yes.
Well, I don't. Good afternoon, ladies and gentlemen. I think we're going to get started. We're at the designated hour and we're live. So welcome to those of you joining us in person from the Michener site. And also thank you for all of you who are joining by live stream. We're glad you're here. I also, as always, want to do a special thanks to our colleague, Tim Chipman, who's keeping the technology running. Thank goodness. Thank you, Tim. And Tim's from the Michener. So again, thank you very much. As you all know, I'm joined by the illustrious Jillian Howard, who's here today and will keep me honest. And we're also today joined remotely for a first by our patient partners. And that's a new addition to this forum and really a very big focus on how we ensure we hear from patients in every possible way and at every possible forum at UHN. So again, thank you for joining us. Let me walk you through a little presentation and then more importantly, open to questions. So just to remind you, we have experimented with a new model where a bunch of you have submitted questions already, and there's some really popular ones. The tough ones are really popular, and I'll get to those very quickly, but Jill will also be auditing those of live questions. So please go to slido.com and enter hashtag UHN0304 if you'd like to add anything. We also did this so that we could ensure that discussion would be robust. But for those of you who couldn't be here and wanted to submit a question, and for those of you who said, gee, I really like that question, we wanted to give you some lead time. Let me look at, in addition, the questions that move up Jill's list will be through a live voting process. So if there are some that you see on your screen that you particularly like, I know we won't get to all of them, please vote for those and we'll do the best we can going forward. And Jill has heard loudly and clearly, you don't want us to edit your questions or summarize them, so we won't be doing that anymore.
Which means that we won't get to all the questions because it's not possible within an hour. So in the audience today, if you have questions, raise your hands. We've got two people to run mics. So we've got Audrey Chu and Megha Bhavsar, who will go up and down the aisles. I want to thank everybody for responding to the feedback survey, and so we will be reading the questions. We want to have frank discussions, and I will read out the questions as they come, but I want to remind everybody that you can still vote in the audience. So I think the top question at the moment has 250 votes, so we'll certainly be dealing with that one. I think we go to the first one.
Do you want me to go through this presentation first?
Yeah.
Okay. So let me just go through a few slides and then we'll get to the important discussion of questions. So a number of you have asked already, and I know you're all talking about it, which is really important, thoughts of the Ontario Health and the People's Health Care Act that the Minister revealed last week. As you know, there are many, many questions about this. The Minister and the Premier's office have dedicated a concept that talks about Ontario health teams, and we are working very closely with them to better understand what that means. So, for example, would UHN be part of a whole bunch of Ontario health teams? Would UHN be an Ontario health team? Would there be some model that blends those two? And I would say at the moment, it's just an evolutionary phase. And stay tuned as we get more information, and as well we're giving government our opinion, whether they want it or not, and I think they do want it. They've been very, very generous in reaching out to ask us what do we think, what would work, what makes sense, and then laterally Ontario Health is also a new institution, so it's the combination of 6 agencies with likely more to come from all we can understand, up to 20 agencies merging into one. And I was very encouraged by the Minister's discussion and Deputy Premier that focused on bringing the best of each of those agencies to all disease categories. So the example she used was Cancer Care Ontario does some amazing stuff to help us provide evidence-based, patient-centered cancer care and collect fantastic data. What if we could have that same level and standard and process for things like mental health, things like aging, areas where we don't have dedicated agencies. So obviously, I think there's some great ideas within that. As always, in implementation, the devil will be in the detail. If any of you didn't hear the minister's announcement, it is available to you online. If you just Google minister's announcement on the People's Healthcare Act, you can review it in detail. I suspect you'll have more hits than you know what to do with. Secondly, I wanted to chat with you about the engagement survey, and I think you want to chat with me about it because it's the #1 question, thankfully. And in so doing, building trust with senior and physician leadership was an area that I think all of us were hoping we'd do better on than we have. So 41% of staff thought that senior management relationships could be improved, and 33% of physicians, sorry, I've got that backwards, 41% were satisfied, and 33% were satisfied with the physician engagement scores. So we really have some significant work to do. I have to admit I was a bit taken aback by those results, and then I went into the literature and looked at some areas, including some work Ernst & Young has done. And it's actually not so unusual as we look at surveys like these at this particular moment in healthcare where people are feeling really stressed. But you know, that's poor solitude to those of us who are feeling less than empowered and less than supported by leaders. So let me come back in the question section and talk to you in detail about some things that I think we should be doing. And I'd really like to hear from all of you about things we should be doing. I want to talk to you about how you can ensure that I hear that through the questions that you post out of these sessions. The next issue that we heard, a great question, was diversity, equity, diversity, and inclusion. And I think a few folks had observed in the old former executive team, as opposed to the current executive leadership form. I'm happy to say that the executive leadership form has a better representation or a better mix of gender, diversity, inclusion, and those deserving of all of the above, those groups deserving of all of the above. But we're not there yet. So I had the privilege of taking part last week in 2 events that were very important. One was the celebration of Black History Month and the legacy of Black leaders. And the second was a program put on by Dr. Gillian Hawker and the University of Toronto about women in medicine, focused on inclusion, diversity, and gender. And suffice to say, while I'm happy to see that 5 of 13 or 6 of 13 in this group are women, we also know that there are broader concepts of diversity and inclusion, and the whole concept of microaggression as we take on these things I'm learning more about, and I'm sure you'll be hearing more about, and I know our human resource team is very focused on. So again, if you have some more questions on that one, more work to do, very attentive to it, very much partnering with the University of Toronto, who's done a terrific job of raising this up in a number of faculties, and stay tuned. So now I think, Jill, we're on to the Slido presentation, and you're going to grill me with the tough ones.
Okay. So there are 109 questions at the moment.
Wow.
On Slido, and people have voted for them. The top question is, how do you plan to address the employee engagement results, which show an extremely high dissatisfaction with the leadership at UHN and in departments in general? 253 people voted for that.
Yeah, well, first of all, thanks for the person or people who asked this question, and thanks for the unity around it. It is probably one of the most important questions that we could possibly consider. I think we're all stepping back at the senior leadership team and beyond. First, I know a number of programs and departments that have already started instituting more rounds and more meetings with staff, which, as we know, many of the staff who have been concerned about this have expressed a view that we just don't have any time with our leaders. We don't have time with our managers, our directors, our supervisors, our chiefs, our division heads. So first and foremost, getting people together and getting them exposed. We also heard loudly and clearly that even if you don't have anything new to tell me, I might have something new to tell you as a staff member, so don't cancel these things. Create the forums, allow people to come to them, not unlike this one, and answer the questions frankly and honestly. recognizing that we all want to be respectful in asking them and respectful in responding to them. Secondly, we have also gone back, and Human Resources is doing a great deal of work in this, but all of the team, and looked at in the literature what's making a difference. We're an academic health science center, and we know that there is some science in inclusion and in building people being seen, being heard, feeling safe, and feeling engaged. So out of our senior management team retreat, the number one issue that came out of that was us agreeing that we needed to work on how people can be heard, how people can feel safe, and how people can feel engaged. So stay tuned. I think you're going to hear much more about that, but also in a way that doesn't add more frustration to people's work life, but actually gives you what I think you're asking for, which is time on task with your leaders, frank, honest answers, even if the answer isn't necessarily one we all love, and rapid response when a question's asked. Let's get back to people quickly, as opposed to it going into the black hole and no one having a response. So won't solve this one overnight, not unique to UHN. I was at something with the Canadian College of Health Leaders, and we did the same survey that we've done internally. And interestingly, these were leaders in healthcare from across many institutions. The numbers were very similar. And to me, that speaks volumes to how stressed people are feeling, how the demands of operating at over 100% occupancy are challenging, how the communication between leaders and those they have the privilege of leading are less than ideal. And last but certainly not least, the relationship management that very large numbers of direct reports put upon people. And we know that we need to actually get face time with each other. So let me come back to you with a very detailed plan on how being seen, being heard, and feeling safe will be focused on at UHN by every leader.
Okay, one of the things that isn't showing on the screen is if you actually go into Slido, each question has replies to it from other people who are weighing in. So it's probably worth going in there and taking a look at that, because that's another method of hearing what people have to say based on the question. The second question, given the escalating costs of housing and space constraints of the facilities at UHN, remote work for staff that have tasks that can be completed remotely is a potential solution. Is HR looking at an organization-wide approach and policy for remote work?
Yeah, great question as well. And yes, the answer is absolutely. We are looking at that. HR leading it, but really truly across the organization. And starting with the question, how might we do that work safely, effectively, with high quality, while seeing people not in the traditional workplace? And what kind of technology infrastructure do we need? So if you feel that there are opportunities within your job category, please reach out to your manager and make sure that they, through HR, let us know about that so that we can very much look at it. The University of Toronto has done a lot of great work in this regard, and it's really helped them in terms of space planning as well. So we are absolutely open to considering how this might be done. There are areas, obviously, particularly clinical areas where we directly serve patients, where that might be more challenging. But increasingly, with technology and with the work we're trying to champion in integrated care, even that may be possible with monitoring centers and digital visits. So 100% on our radar.
Okay. Third question. Frontline staff often have brilliant solutions to problems that will save money in the long run, but for which there is no investment at present. Mid-level management often block these ideas. How can UHN become a more vertically integrated hospital to encourage staff broadly to participate?
Yeah, it's another great question. So I think three ways. One, draw it to the attention of your leader, of your manager, your director, your chief, whoever you actually report to. If you don't feel like that's been given the appropriate attention, please use this form. So we read all of these questions, and thanks to Ingrid and Jill and others, we try to get answers to you on all of them. I want to apologize because I think a couple of years ago, Darlene, we did go out and solicit this information, and I don't think we got back to people in as robust a way as we could. So with Darlene's leadership, we're actually looking at what's been recommended previously. And we're going to come back out to the organization through this form and say, what did we hear and what's possible out of those? But if you have some ideas, please share them with us. All of this gets to the senior team So if you have some great ideas, please email me these on this, this form, and we'll make sure they get to the right people. And as far as middle managers blocking it, we've had a little bit of a conversation about that. It probably isn't blockage as much as it is a discovery that some of the great ideas, for example, are inconsistent with our labor agreement. So a negotiated contract or a unionized contract or some good reason. But if we haven't gotten back to you, the person who came up with the great idea, to explain why that can't be implemented, then we haven't closed the loop and we haven't done a great job on communication. So we absolutely should and will do a better job of that.
Okay, the next question I think you addressed earlier. The entire UHN senior leadership table is now white males following the departure of Bella Martin. How do you plan to develop diversity in leadership at UHN if it doesn't exist at the most senior table?
Yeah, so as I mentioned, thinking a lot about this one, actually getting some education myself on it as well. And I think, again, that this most senior table is about 5 women and the remainder of 13 being men. That still isn't where we need to be, and it doesn't speak to diversity and equity across many other groups rather than gender. So again, we're looking at that one very carefully. 3 things, again, the literature talks to us about. One is engagement and encouraging application. So you can only hire people who apply. The second is fostering and mentorship, so that we are ensuring that the complexion of UHN in every possible facet is reflected in applicant pools, and we can do a much better job of that. And the third is, I think, building on the great work that I've seen from the University of Toronto, particularly the Department of Medicine, who's really done some great work on diversity seeking and diversity attracting. So I think we can do a much better job on that one. I know Human Resources is also looking at the way we attract people. And last but not least, when we see a lack of diverse candidate pool, can we be reaching out to people? While we can't promise anyone a job when it's a competitive process, if we don't have diverse applicants, then should we be pausing and looking at how we attract a broader applicant pool when or if that might be possible? And I think we'll be doing a bit more work on that one. Never easy, but work that is essential to UHN's future. We also know, there's again a literature on this, that diverse teams have much higher performance standards, and actually in research teams, diverse teams actually publish more creative work. So there's a lot of evidence about why diversity matters, and it is high on our agenda. It's also, I should tell you, extremely high on the board's agenda. There isn't a board meeting that goes by that it doesn't come up. All of our board leaders are also working in organizations who are struggling to see diversity and inclusion much more reflective, and as are we, so we'll learn with them and from them.
So the next question, I am going to read it, and then I'm going to give you an editorial comment on it. How do you address continued poor results from management, as well as units where no budget is always the excuse for not hiring much needed staff? Maybe it's time to shuffle management or some kind of restructuring instead of cutting more staff. The sort of editorial comment, I would say, from working with you, Kevin, is that you have the expectation that everybody's budget will be balanced.
So I do have that expectation, and again, I think that there's always a time when you have to go back and say, is the budget adequate? If we need to rebalance the budget, then that's part of the process that Darlene and her team lead the process. All of the senior team lead the outcome. But unfortunately, we don't now have, and probably never will, have all the resources we'd love to have to deploy the kind of people that might benefit our patients and benefit scholarship at UHN. I'm going to reject the view that there's a bunch of managers lying around here not doing much. The managers that I interact with are working really hard, and I again think that everyone's trying to bring their piece of the pie to serving the patient. We look very carefully at our administrative spend as an example, and we actually at UHN have targeted non-clinical areas often higher than clinical areas in our savings targets. But management is also important, as we know when we get into examples where we've done a poor job of it. And maybe we could all think of some examples where if we'd had better, stronger, dedicated leadership as opposed to expecting people to take on massive change processes off the corner of their desk, they might have worked out better. So I think on this one, I wish I had a simple answer for you. I hope technology is going to help us, that we'll actually be able to use some emerging technologies. We're about to embark. It'll be more work in the short term and hopefully gain in the longer term. About to embark on a new health information system that I hope will make life easier for patients and clinicians. But suffice to say, I don't have a good answer to say how can we put more resources at the front line when every year we start underwater by about 3%. So that means finding $30 to $35 million every April the 1st. And that number goes down only based on the increase we receive from government. So, you know what, I wish I had a better answer. I think the last piece, maybe the new structure that the Minister and Deputy Premier has described, will allow us to think about partnerships in different ways and getting patients out of hospital more quickly and working more collaboratively with community-based providers. I hope that might make the quality of work life for hospital-based providers a little less frustrating and certainly allow our flow to occur so that people actually have adequate beds and infrastructure to look after patients, and flow could be improved.
Okay, next question, from a broad question to a very specific. I notice many patients and staff get stranded on the ground floor as all elevators are either going up or down with no alternating direction. This leaves patients frustrated as they have to stand longer to get their appointment. Are there any plans to upgrade the elevator system throughout UHN? I suspect that at least there are some people in the audience who are frustrated by this, but probably none more so than the people in building services who would want the elevators to work really, really well.
Yes. Yeah, one of the big challenges that I've mentioned here before at UHN is we have a lot of aging infrastructure, and we've got to put a lot of energy into upgrading it. But I'm grateful Ron Swale is here, and if someone would hand him a microphone, I'd ask Ron to join me in addressing this challenging issue.
Certainly. So this is a real challenge for UHN across many of the sites, and it's one of the first things that I took on when I came to UHN just a little over a year ago. So this isn't a simple answer. There's many factors that affect performance of elevators. Poor condition is one, but also the design of the building, you know, the vision of the designers in the beginning of the building, how many elevators you actually put in a building. You can't really retrofit a building to add new elevators. It's incredibly hard to do. It's also affected by loads, peak demand. If everyone's coming in at the same time, you can have peaks and valleys. It's affected by maintenance, and it's affected by how your service contractor, how they respond when there's breakdowns, because there's always going to be breakdowns. So to answer the second or the last part of the question, is there a plan? Yes, there is a plan. There has been a number of retrofits at UHN over the past several years. Surprisingly, Princess Margaret has all their passenger elevators have been retrofitted. We've had retrofits at Toronto General and also at Toronto Western. In the coming year, we have retrofits planned for the Bickle site, all of the elevators there, Hillcrest, all of the elevators at that site, and also at TRI, the university location. So there will be more coming. It takes about 4 months to retrofit a cab, so it takes a very long time, so you have to go through pain to actually upgrade these units. But even when they're done, it doesn't instantaneously necessarily change from people waiting in the main floor. At Princess Margaret, we brought in a consultant to fine-tune those elevators to make them work as well as possible. And we also have other issues such as the construction that affect performance of those elevators. We've moved the blood lab off the main floor to the 3rd floor. We've moved the education center from the main floor to the 2nd floor. And there's no way for patients to get to those locations except for the elevator. So that just adds to the load. So it's a very challenging problem. It's something that my department's very focused on through the Director of Building Operations, Stuart Nagner. For over a year, he's been doing metrics on the performance, on the number of breakdowns, and how quickly our service contractors are responding to breakdowns. So we're committed to providing the best service we can, but we are limited in some locations by peaks of the number of people that are actually going through those buildings and how many units we have. So that's a long
Thank you.
answer to
No, it's a
fairly simple question.
It's a simple question, but a complicated process. So maybe just two things that I'd add to Ron's comments, and thanks, Ron, for doing that so quickly. One, we all know that the physical plants, we really need to re-examine all of our campuses, that a number of them are really quite tired. And I know the economics of this are challenging, but we are in the middle of a master planning exercise. So we'll be going back and looking at that, and the ministry requires us, as we should, to plan 20 or 30 years out when we look at volume, so we've got some good work going on. The second you've already raised, which is a great idea, do we need as many people to work at the existing sites, or could we do more work from home, which would lighten the load in our buildings? And in every case where that's possible, we'll be exploring that. And last but not least, I hope, as we get into a more integrated care environment and we're able to care for more people more quickly at home and use some digital technologies to help us do monitoring and engagement with patients, perhaps the flow of patients to the hospital sites will decrease, and actually we'll see more providers out in the community and more support at home. So I know that'll be a 5-year journey in either case, but we're attentive to it.
Okay, you've touched a little bit on this next question. Hi, Kevin. How the announcement of the ministry about the creation of local health teams in Ontario responsible for integration of care will change the way we provide care in UHN, considering that we treat so many patients from outside Toronto, being a tertiary quaternary hospital?
Yeah, again, a great question, and we've raised that same issue with the ministry and with the minister's office. We've also begun talking with what we call the Council of Academic Hospitals, so the 22 hospital corporations in Ontario that are the core teaching and research hospitals of Ontario, and really looking at the question, would we be a health team? Would we be part of many health teams? Would we be separate, particularly for our tertiary and quaternary piece? And at the moment, the encouraging piece is the ministry is actually coming back and saying, why don't you suggest to us the best model to work? So I know we have some meetings scheduled and coming up where we'll actually have that opportunity. I'm also very encouraged by Deputy Premier Elliott's announcement that this wasn't going to be a quick, we're going to go overnight from this model to that model, but that an evolution was required and that we're not going to rush it. We're going to actually go a little bit slowly and incorporate it in a way that best meets the needs of patients. And I'm also encouraged she is talking wisely about the quality of work life, that really thinking about for those folks on the front line. Last but not least, the challenge of tying primary care in. Every time in Ontario we do a restructuring, every time we kind of look at improving the system, we all know that a more integrated primary care system is essential. I think in this reshuffle, this government is very focused on how do you get that a little more right than it is today, not only for the patient, but wrapping care around primary care providers to make it easier for referral and easier to connect patients with other provider groups. So, you know what, as you know, I'm an optimistic person, the glass is half full, and I'm hoping that we'll have a chance to give them advice so that we can tell them how to do it and they can tell us why and what they'd like done.
Okay, next question. We go through yearly performance evaluations by management, but I don't remember ever being offered the opportunity to evaluate or provide feedback to our manager. Did we miss something?
Well, it's a great question again, and actually all of our management reviews have an opportunity for some random selection of people outside the list of people we each provide to human resources. So I'll just pick on me. When the board evaluates me, I get to identify some people that I think they should consult, and then the board, working with human resources, identifies some other people that I don't have input into. And I believe, Emma, that that's exactly the same process we use here, that there are some random selected people in addition to those that managers nominate. If you haven't had that opportunity, and as we're moving through performance review, reach out to human resources and say, you know what, I'd like to have the opportunity. But in that model, you're really asking to do so for some constructive feedback. What is the manager's strengths? What could the manager improve upon? And vice versa, what could the staff do to better support the manager? What you're really saying in this question is, I'm not happy with my manager, that's probably not something you should wait to be asked to take part in a 360 or a performance review. Go to your manager, have that frank feedback if you feel safe. If you don't feel safe, then either go to human resources or go to the person that the manager reports to and ensure that you voice those concerns.
So I think the next question sort of follows into this question, because it says, how do you address the hierarchy culture in which some staff don't dare to voice their concerns due to feeling unsafe and insecure to lose their jobs? How do you address disengagement and poor performance results due to this insecurity?
Emma, I'm not sure if you want to add anything. Let me take a stab. And so we actually have a very low fire rate at UHN, very low, like lower than most organizations. We do have more people who, particularly early in their career, a higher number than I'd like to see within the first 2 years turnover. But I want to assure you that this is a safe environment. If you don't feel safe with your manager, then there are a number of other vehicles, and Emma can comment on them. But ultimately, no one should ever feel bullied. And as long as you're bringing your concerns to the table respectfully and generously, because let me be frank, there's lots of times when managers, directors, senior leaders, physician leaders, really are carrying out the strategic direction of the organization. You may not like that strategic direction, or you may not like the decision. That should be separate from feeling bullied or feeling afraid. No one at UHN should ever feel bullied or afraid, and if you do, please reach out.
I think you gave the answer. Bottom line is that we would like you all to feel that you have a number of vehicles or places that you can go to if you don't feel comfortable speaking directly with your manager. So obviously, the manager's director is one place. Your department's HR representative is another vehicle. The diversity mediation office is another vehicle, and very often I know people go there. And frankly, quite a few people even recently have reached out to me by email and asked me who they could discuss it with. So I guess what I'm saying is that you should try to find someone that you can speak with, and then that someone is really responsible for ensuring that if they're not the right person, that they refer you to the right person, or that they raise it with the right person to try to assist you.
Don't avoid dealing with this at the time, right? So the worst thing for any of us, put yourself in that position. If I came to you and said, you know what, Barry, 3 months ago you did something or said something that maybe you remember or maybe you don't, is way different than 3 days ago or 3 hours ago we had an interaction that was inconsistent with the values of UHN and the behaviors. So I know it's not always easy in the moment, but giving people feedback as quickly as possible with examples allows all of us to improve. If it's an ongoing behavioral issue, then I'd encourage you to go, as Emma said, through your human resource representative, or include the person to whom they report.
I guess the other thing that I'd just underline is the whole notion of just because you don't like a direction or the way things are going, that isn't actually bullying. I mean, your leader has the responsibility to actually sort of bring people to, this is where we're going, this is how we're going to do it, and I think sometimes people do get a bit confused. Do you have plans to actively encourage senior leaders to develop young talent in a meaningful way? I often notice that new hires with master's degree and lots of experience with volunteer work in the communities often are tasked with taking minutes at meetings and discouraged from speaking.
So I was disappointed to hear this, but the answer is obviously yes. The way we're going to see people progress through a rewarding career at UHN is for them to have progressively senior experience. I can certainly remember in the days when I was taking minutes at meetings, and that was part of my learning as well. So, but no one it shouldn't be suggested that anyone's idea isn't welcome at a meeting at UHN. But yes, there is a career progression planning process. Again, human resources plays an active role in that. We're also looking now at creating some fora, thinking about maybe creating some management rounds where we ask some young people to come and present some of the latest literature, and we can hear that literature and debate it as groups. We're also, for the strategic plan, creating, you'll have seen on your email, an advisory group made up of our younger folks in the organization who might be interested in being a bit of a panel to allow the programs and services to bring their ideas, bring their objectives, and give them some feedback. And also get that from a different generational view than some of us with a bit more gray hair or increasingly a bit less hair of any color. So yes, yes, we will absolutely be focused on that.
Yeah, I'm probably going to date myself, but I can remember stuffing a lot of envelopes when I started out. And so I think I would add that you've got to do the best job for the job that you've been asked to do, and then work your way through a system. Historically, UHN has had the same issues with staff dissatisfaction, a culture of being afraid to speak up, and leadership, director level up, being bullies, yet being rewarded by bonuses, outstanding PES scores, raises, etc. When are you going to start really looking at changes to leadership?
So I wasn't aware of that history, if that is in fact the truth. But you know what, I would say we're trying very, very, very hard to go back and look at performance metrics, behaviors. I hope you'll all feel that this format is a helpful and frank approach. A number of you are emailing me directly or calling me directly and giving me feedback. When I get that feedback, when someone writes and says, well, Jill did this or Jill did that, I'm not shy to let Jill know. That doesn't mean that it's true, but that means that someone perceived it. So I am reaching out to individuals individually and giving them the feedback, not in a vehicle to be hurtful, and some have received it that way, because I maybe don't interact with them all the time. And if I ever reach out to any of you, please don't feel that you're only hearing from me on the negative. But I don't want someone emailing me a criticism of any member of Team UHN that you don't have the opportunity to both hear and respond to. And so that's occurring. Secondly, I think we're refining our annual performance review processes. And I know on the medical side, Brian and Anil are doing a lot of work, really looking again at that performance feedback process. I've talked about this before. One of the important ingredients is making sure people hear when their behaviors are less than ideal and inconsistent with our values and our culture. And that is occurring. My view is that's better to occur quietly and see if behaviors are shifting. I'd like to hear from you. Are you, over the next year, we should revisit this, seeing those kinds of behaviors shift in your leadership? And if you're not, again, I'd want to hear that, and we may have to take a more aggressive stance on it. But so far, those people that I've talked to who may have a bit of a reputation of being a bull in a china shop have, number one, been a bit surprised that they are perceived that way, because maybe they haven't been told that lately. Number two, indicated a willingness to be more sensitive to it and improve. And number three, they were grateful actually for the feedback. So keep giving me feedback on this one if you see behaviors that are inconsistent. And don't forget to give your manager, director, chief, whatever, that direct feedback as long as you feel safe, and go to their one-up every time after that.
Yeah, when I read this question, I mean, I know this is an open forum with you, but when they say, what are you going to do about it, it's really all of us. What are we all going to do about this? Because I don't think you are going to do this alone.
I'd like to second that. Yeah, and remember, let me also be a bit sympathetic, because I think if you're a manager hearing this discussion, we're only hearing gee, how could they improve? I hope each of our folks who are not necessarily in a leadership position, but a followership position, are also asking the same question, right? So I can honestly say, I chatted with a clinical manager the other day who who had about 100 reports, 100 direct reports on shifts around the clock. And they were really genuinely trying to figure out, how can I be accessible, available, supportive? It wasn't easy. So part of good leadership is also good followership. And are you supporting your manager in a way that can allow them to be successful and bring out the best in their behaviors as well?
Okay, people are voting, so this one has moved up a bit. How do you address incompetency and leadership skills in some levels of management and mid-level leaders?
So there's a great tweet yesterday for those of you who follow Twitter, and it was actually about physician leaders. And the tweet was actually about how little we do to prepare physicians who take on leadership roles. And the question may or may not include them, but I think historically we've often said, you know, Dr. X is a great, or whatever clinician, Nurse Y, physiotherapy Z, psychologist A, you know what, great clinician, great researcher, let's make them head of the department, let's make them a program director, let's make them whatever. And frankly, they've never had any management training. So 3 things I think are happening. 1, particularly amongst young physicians, they're actually getting the training. And 2, we're investing in that as well. So I think both through York and through Rotman and the U of T more broadly, there are a number of programs to ensure that people get that. Secondly, both Brian and all of the members of the Executive Management Forum, Leadership Forum, are being much more attentive in the process of recruitment around both experience and support. And last but not least, coaching. That particularly for new managers, we're looking at, do you have a coach either internally or in some cases externally if really required, we're being mindful of the cost, who can help you be successful. And we know that one of the most important ingredients in the success of a new manager is someone who they can, without risk, lean on, ask for help, get some feedback from. And if your first management experience is successful, you tend to do well in future years. So as always, first about education, second about frank but kind feedback, and third about evaluating performance improvement and hearing directly from those they're leading.
Okay, some units at Toronto Western were recently informed in order to raise $3 million for budget issues at the site, there would be no RN replacement for a first sick call. Research indicates increased RN patient ratios, I guess that would be decreased RN patient ratios, compromise the safety and quality of care. Why are RNs being overlooked and understaffed to save money?
Yeah, so I looked into this issue on a previous question in a call that I had. It is absolutely not a policy direction. This would be very much what's happening on the unit. And it would also dovetail well, I don't know if Joy's here today, but with the work that Joy and her team have been doing on acuity-based staffing. And never would we actually suggest that you don't staff adequately. There may be an issue of acuity, skill mix, so all sorts of reasons, but there is absolutely no policy or directive not to replace first sick call. It comes back down to the judgment of the leader in that unit as to the needs of those patients, the skill mix of those patients, and the ratio based on illness. So I apologize that that's been the perception, but that's definitely not a direction of the organization.
At the last forum, we asked about leadership term limits. You talked about clinical leaders. What about management leaders? How much more evidence besides the engagement survey and poor organizational performance is needed to change management leadership everywhere? They are tired, and so are we.
Yeah. First of all, I was very sorry to read this one and hear that again was the perception. So, you know, I think there's very little evidence that turning management leaders over more regularly actually builds a stronger culture. As a matter of fact, high turnover rates usually result in a lower performance as opposed to continuity. When it comes to are people quote unquote in their role for too long? Well, in academic roles particularly, they tend to be 5-year terms. So after 10 years, sometimes in exceptional circumstances a third term, but mostly 10 years or 10 to 12, we do see that turnover. many of us, I can assure you, I will turn over before 12 years occurs. But I think also we're starting to see, with the kind of circular career progression that this generation of leaders is experiencing, I think you're going to see this happen purely by a change in the generational leadership that's emerging. Each year we do evaluate the leadership teams and the leaders in each domain. And if there's a performance issue, then we should deal with that, either by support and training, or if the person's perhaps outlived their best years at UHN, to support them in finding a job they can be more successful in. But I don't think that you'd be well served by saying, okay, Jill, you've been here 10 years, you're out, right? So you've been here more than 10 years. Yeah. Yeah. But are there occasions where we've gotten stale, we haven't rotated people enough, we haven't maybe challenged some new thinking? Probably there are. I think we want to strike the balance, but I'm probably not in favor of simply saying it's just a clear 10-year cycle and out. In the positions where we do take terms, the people aren't leaving UHN. So let's say you've been part of you've had an academic chair, you've had an endowed chair, you've had some leadership position. They're not leaving the organization when they complete that unless they wish to. They're transitioning back to another role, often a clinical role, or often going back to their scientific life. So I'd hate for people to think I couldn't possibly have a life cycle of more than 10 years at UHN. I don't think that would breed the kind of culture that we're hoping for. That having been said, can we do a better job of sticking to our terms and turning leaders over and moving them around and rotating them so they stay fresh? Absolutely.
Sometimes we are introduced to new hires at UHN, but there are no public or even internal postings for these roles. How is that fair, especially for senior positions?
Yeah, so most of the roles, I would say, we do post, unless we've come across someone who we say this is a very, very unique skill set. The other, where we may not post, I can think of one recently, is a job that is often shared between we and the University of Toronto, or an academic institution. So we've identified someone who's an academic. We've identified that there's a role for them that would benefit UHN and benefit their scholarly work. And oftentimes those are externally funded in part or in full. So those would be the jobs that we wouldn't post for. And perhaps if you have a very, very, very focused skill set. Last, and I'll just be very honest about this, I don't do this very often, but when you've found an exceptional candidate who you really want to bring into your team, then I'm not going to put people through a pretend exercise and say, let's pretend this is a real competition, but you don't have a chance in getting that job. I would much rather just be honest with you and say, here's why we chose that person. Here's the skill set that they need. Here's the benefit, the behaviors that we need right now. Here's the relationships to other organizations that make it appropriate. So if you have any examples where this happened, please email me specifically and I'll answer it directly.
Dr. Smith, could you please address the attendance management program? It is frustrating that people are ill and are reprimanded if they are off, but if they come in, they are told that they should not be here. I am frustrated, and please help us work in a better environment. Thank you.
So again, I'm sorry that this is the perception. I hope that we are not ever saying to someone who is legitimately sick that you should be here or that you feel harassed for not being here. That having been said, we do have a challenge in sick time at times. And if you look different than the average employee, and I know averages can skew, but if you look different than the average employee, and our occupational health folks don't know why, and I appreciate this is your personal business, you don't have to share this information with us, but if you're kind of a flashing light of, wow, you are away a lot, or it's interesting you're away every Friday and a lot of Mondays, frankly, that does pop up, and we have to ask the question, is this illness or is this someone who's frankly taking advantage of the system? So for anyone who's legitimately sick, stay home, absolutely and completely. And if you have any grief from that, I think you should go back to occupational health and safety and give them that feedback. If you really are a huge consumer of sick days and you're willing to explain to occupational health and safety why that is, a chronic illness, whatever it happens to be, then again, we should have a solution. If you are way more than anybody else and you're a flashing light on our scorecard, I think you're going to continue to have questions. And that's just, frankly, our responsibility to steward scarce resources.
Okay, people are voting as this goes. So the next one, there's a serious need for reorganization. Responsibilities need to be clearly defined. A lot of redundancy, red tape, and politics. Multiple directors working on one project with constant struggle for ownership, leading to big waste of resources.
So that's a very broad allegation, and I'm not suggesting it's not true, but I need you to give me specifics. Right? So if any of you have an example where that's occurring, please email me, right? And I can assure you if that's occurring, it's an error of omission, not commission. So I will take that back to the right leadership table. I'll give people the feedback. You know that I am desperately in quest of simplicity. And I still know that there are a lot of complex processes here, and we are very meeting focused. So I, like you, want to clean this up. I'm not going to ascribe malintent. I think there's someone. I think if that's occurring, that ultimately that's my fault, and I take responsibility for that. So please give me very specific examples. I will go back and review it with the people whose responsibility it is to enact those.
Okay, this question, there seems to be a lack of accountability in enforcing our smoke-free grounds. It's embarrassing for the organization to see staff in UHN uniform, nurses, doctors, facilities, even security, smoking in restricted areas, yet I see it daily. What can be done to improve staff and patient experiences?
I could not agree with you more. I saw it this morning. So my first reaction is trying to be a sympathetic one, although I was freezing this morning, so I wasn't feeling overly sympathetic. And walking through a haze of smoke on your way into a hospital that does lung transplantation, can be often frustrating. And across all of our sites, we treat patients who are negatively affected by smoke and addictions. You know what? One, I think if you know speak to the people. Right? I know I have spoken to a few people who have had choice words for me in response to my suggestions, and they are 4-letter words, which I've smiled and nodded and moved on. On occasion, I've called my friends in security and said, you know what, and I know how busy our security folks are on challenging issues, but you know what, we need to get people to move along. As importantly, if it's a staff member, we want to support you in ending your smoking addiction. So please reach out to occupational health and safety. The more times you try to quit, the more likely you will be to quit. So we have programs that we want to support you on. And last but not least, there's the bylaw officer, and we do call the bylaw officer not infrequently. A number of us have put forward to a now passed government that said you should suspend the 9 meters, 30 feet rule, and you should say the entire block on which healthcare facilities reside are non-smoking areas, so that clients, patients, families don't have to walk through a haze of smoke. We'll see if the new government picks that up, but I simply couldn't agree with you more. There's no reason for that to happen, and equally, there's no reason to leave butts all over the place if you have respect for UHN.
So I too couldn't agree more for very personal reasons, and I did see somewhere in the literature there was a hospital in England who put up loudspeakers, and people, when they saw it, could push a button. And the loudspeakers would essentially say, you're smoking on the grounds of the hospital, you really need to move off hospital grounds. It's kind of Big Brother, but there you go.
You're smoking on the grounds of the hospital, kindly move off.
There you go. Yes, your radio voice.
My radio voice is coming on now. So that's a great idea. Ron's got that one along with 1,000 others, right? But I also want to remind people it's a really tough addiction.
Yes.
And we want to try to support people to end their addiction as well.
I had a GP tell me one time, it's a bit like when you're addicted to smoking, it's a bit like telling people to stop breathing. They can't really do it for a very long time without a lot of support. So the more you try and quit, the more likelier it is that you will be able to quit. With the recent announcement from the Ontario government on the new Ontario Health Super Agency, what do you know so far that we haven't heard? How will this agency impact UHN patients and staff?
So this is probably the wrong forum for me to do the rumor mill, because it'll become fact, not fiction. And you know what? We've heard lots of rumors, but I'd say my real honest take, talking to the minister's office, talking to the deputy minister's office and a number of the senior officials of the government. I also am very privileged to chair one of the agencies that might be affected. It's called Core Health, the old Ontario Stroke Network and Cardiac Care Network. And I just think we're very early on, and I really hear a receptiveness to listening to the field. The Deputy Premier at her announcement was super clear. We no longer want to try to micromanage the environment. We want to identify where the system's improvement needs to be seen. And we recognize that University Avenue and Brockville and Kapuskasing and Petawawa need to do that differently. So I'm quite encouraged by that. Like you, I'm scratching my head a bit on Super Agency or Health Ontario and Ontario Health Teams. But I have a number of meetings this week to try to clarify those, and as soon as more clarity is available, I'll give that to you. I'm going to suggest we shouldn't wait for government to tell us how to do it, because they don't deliver care. They've introduced some legislation. I would encourage each of you in your programs, services, divisions, sites, whatever, however your affinity to UHN, to think about, based on what you've heard from the minister, what do you want to do differently and how? And we should take that to the ministry after we consolidate it internally.
So I'm very conscious of the time. We've just got a few minutes left. And so the next question, and we're down to the questions that got 50 votes, so we're not doing too badly. Is there any plan to improve the intranet in the near future? I think it could be a great resource or tool for all staff here at UHN to improve patient care. Poor design and search functions make it difficult to use, often having to look up information on the public website instead. I'm going to add an editorial
Please
comment
do.
there. So we're responsible, Public Affairs is responsible, excuse me, for the public site. The intranet has been with us for a while. See,
Please move away from the doors. You are smoking near a public hospital.
I'm all choked up about this subject. It does occur to me that there are a lot of things that could be put on the public website and really reduce the amount of material that's on the intranet to make it very, very specific for staff and the organization. So.
Yeah, no, it's a, you know what, I'm a neophyte on this one, but can I ask you to please email David Jaffrey, give a copy to me, and David will make sure that it gets to the right people as well as Jill. Of course, we know that electronic infrastructure is how we all do our work, frankly, how much of our socialization occurs today. So I'd love to hear some specific examples of what you'd like to see that could be more effective, and we're completely open to those.
This topic gets me all choked up, apparently,
yes,
because
indeed.
I'm a bit afraid of the work, and I do want to say to everybody, this will be a major project to do. So I don't want to underemphasize, and I think UHN Digital already has a lot of major work ahead of them.
You know what? It's a great comment. So I should ask you to adjust expectations on digital. And in the next day or so, we are going out to the marketplace with the one thing that I heard from you when I arrived over and over and over again. Please provide us with a state-of-the-art digital electronic health record. So I'm very pleased to say that we are about to go to the marketplace to secure one. In doing so, with the expense and more importantly, bandwidth that's going to consume, I've gone back with the digital team and asked the question, what are we going to stop doing to do this really well and effectively? It is the most important investment we'll certainly make, or one of the most important investments we'll make during my my time at UHN, that, and I hope physical plant redevelopment and the continued strengthening of quality, safety, and research and education. A number of projects we are going to have to say, we're pausing on these until we get our HIS, our Health Information System, up and running. I know that may frustrate a few of you, but if we don't get this foundational piece right, it will be fundamentally broken for the future, and we just can't afford to let that happen. So I couldn't echo that comment more strongly.
And with that, we're,
One more comment,
One more.
Madam Chair.
Yes.
I want to particularly recognize Scott McIntaggart, who is here in the room with us today. Scott, last week, we announced he's going to be stepping down after 38 years of dedicated service, starting first as a frontline nurse and ending as one of our most senior leaders at UHN. Scott, thank you for 38 years of dedicated service. We will roast you at another time, but we will host you today. And very best of luck in the future. Please, let's close by thanking Scott.